So I'd like to thank Claudio for inviting me today and hopefully extend his very nice presentation on heart-kidney interactions into something that can bridge into where we go later in the session and hopefully into where we go later this afternoon. There's another session on biomarkers and acute kidney injury, and I would encourage everybody to attend that. But over the next 20 minutes, I would like to discuss some of the emerging cardio-renal biomarkers and focus specifically on heart failure, acute kidney injury, and acute kidney injury in acute decompensated heart failure. So when I begin these discussions with my fellows and trainees, I like to kind of establish some expectations for what we have for a biomarker. Can they help us diagnose heart failure or acute kidney injury or identify something else altogether? Can they help us select and or titrate a therapy and our management of these patients? But more importantly, can they help us risk stratify? Can they help us identify early on in the disease course the need for hospitalization or more advanced disease, whether we need to consider transplantation, device implantation, and or even palliative care? And I think this is a very nice illustration of everything that we're going to kind of go over through this talk and maybe set the stage for later on and very kind of illustrate and extend what Dr. Ronco talked, this bi-directional relationship between heart failure and acute kidney injury, as well as markers here on the left in that relationship. You can see here reductions in cardiac output, as you would see in cardiac and heart failure, that lead to these neurohumoral mechanisms, inappropriate activation of the renin-angiotensin system or the sympathetic nervous system that generate markers in and of themselves that lead to then kidney ischemia, activating all these inflammatory oxidative pathways, uremic solute retention, the subsequent volume retention that leads to left ventricular hypertrophy, remodeling, failure, and generation of its own independent markers in that context. So you can see over here, you're not really getting the arrow here on the left here, but you can see on the left the markers, kind of some of the established markers for heart failure, markers on the top of cell injury, some of the accepted cardiac-specific troponins, myocardial strain, the natriuretic peptides, fibrosis and tissue remodeling, ST2, and galectin-3, which we're going to kind of move into here over the next couple of minutes, atherosclerosis and plaque rupture, and then more importantly for me as a nephrologist, markers of kidney injury that you can see here on the right. So we're going to move beyond just the traditional discussions of proteinuria and creatinine, estimating GFR, and move into cystatin C, markers of acute injury, KIM1, interleukin-18, NGAL, beta-NAG, some of the others as we move through this talk. Now, some of the more established markers for heart failure are the natriuretic peptides. We commonly use these in our everyday practice, proBNP or BNP, and some of the others for acute coronary syndromes like the cardiac-specific troponins. But there are a couple new ones out there that are FDA approved in the United States, but really have unclear utility currently, ST2 and galectin-3. So we're going to talk about those just a little bit. This is a schematic that illustrates these two markers very nicely, looking at galectin-3 here on the left, which is really a marker of fibrosis generation, and then ST2 on the right, which is released in response to cardiomyocyte strain. Now, in this context, ST2, or soluble suppressor of tumorigenicity 2, is a member of the interleukin-2 receptor family. This is a protein that is transmembrane and is also found in the circulation in soluble form. The ligand for ST2 was recently identified as interleukin-33 and conceptually kind of links the concept of cardiomyocyte strain to inflammation in heart tissue. So over time, a number of investigators have looked at ST2 individually on heart failure outcomes, but some of the best data has been to look at this in combination with the natriuretic peptides. So I'm not going to present the volume of information. This is just one study kind of illustrating this point very nicely. This is data from the MAD study, or the multi-center automated defibrillator study, looking at roughly about 700 samples. as a post hoc analysis. And let's see. And you can see here on the left, in combination with the natriuretic peptides, it has its strongest risk prediction for ventricular arrhythmia, mortality, and a mortality related to heart failure in combination with the natriuretic peptides. So chew on this for a few minutes as we move into the next biomarker, galectin-3. This is secreted by macrophages in response to the transdifferentiation of fibroblasts into myofibroblasts in heart tissue, really at that point at which they become extracellular matrix secreting myofibroblasts, where they're generating fibrotic products, collagens, vimentin, fibronectin, and all the others that we like to follow. So very important marker at that point of early differentiation in heart failure. So again, very similar to ST2, galectin-3 has been looked at individually related to heart failure outcomes, but some of the best data has been in combination with the natriuretic peptides. This is one looking at the heart failure action study where galectin-3 in combination here with proBNP had its best risk prediction in combination on hospitalization-free survival. Also in the study, the levels of which were most strongly correlated with New York Heart Association Class 3 signs and symptoms, low systolic blood pressure, higher serum creatinine, and other indices of heart failure severity, such as hyponatremia here. So when we look at the collective data on biomarkers in heart failure, this is a meta-analysis that was used to support an American Heart Association consensus statement on biomarkers. This looked at available evidence on natriuretic peptides in all heart failure trials. And essentially you can see there was a lot of individual variability between the individual trials, but largely the weighted mean average with good heterogeneity in this meta-analysis supported the use of adding biomarkers to the management of your patient with heart failure. So that was pretty much their consensus, that using a biomarker in this context, the best available evidence at the time was natriuretic peptides in managing your patients. Now, I presented good data on single use of biomarkers, natriuretic peptides, right? And I've talked to you about combining that with some of the newer ones, galectin-3 and ST2, but more isn't necessarily better. When when some of the Framingham investigators looked at a combination or a constellation of biomarkers, this didn't necessarily hold true. On the left, you can see where they looked at the combination of BNP, troponins, GDF15, ST2, amongst about 3 or 4 other biomarkers. There was consistent elevations in heart failure, but when they looked at it on the ROC curves and looked at the sensitivity specificity for risk prediction, it didn't really help improve risk prediction when they combined this constellation of markers. Now, kind of surprising, right? But when they looked at the individual markers, they did a stepwise regression looking at the individual markers. Several of these kind of fell out as very important. No surprise, C or P, the natriuretic peptides, markers of the renin-angiotensin system, homocysteine. But the two that I would like to kind of focus on, BNP, the natriuretic peptide, and proteinuria, urine albumin to creatinine ratio. Now, as a nephrologist, I'm not going to let this one go, right? We've been talking about this heart-kidney interaction, this bidirectional relationship. So I think it's incumbent to understand that the presence of CKD is common in our heart failure patients, especially those with acute decompensated heart failure. This is so here looking at this one study, just that CKD is highly prevalent, but importantly, its presence is important in risk prediction for mortality in these patients. Now, what's also important to consider, you heard this from Claudio a few minutes ago, is looking at declining kidney function or worsening renal function in these trials. This is a Cochrane database meta-analysis of over 50,000 individuals in heart failure trials with increases in serum creatinine, whether there was established baseline CKD or not. So increases in serum creatinine predict very consistently mortality in these trials. But what's also important is not necessarily the concept of worsening renal function and increases in serum creatinine, but how we apply these criteria for diagnosing acute kidney injury in for these trials, but also in biomarker development. There's been some discrepancy and variability in the data in these trials because we haven't been very consistent in how we apply the criteria. So I'm not going to go over the criteria, but just to kind of make the point that we need to use these criteria and where we go. This is a very nice study published last year kind of supporting this point that when you apply these criteria, more specifically the KDIGO criteria, and use a biomarker, in this study, TIMP1 and glutathione transferase, when you use these together, you can not only help improve your identification of acute kidney injury, but it will help you apply a management scheme. Here was a very strict intervention using saline, removing offending agents, ACE inhibitors and or ARBs, or other interventions. You can see very clearly when using criteria and a biomarker, you can improve your management scheme of these patients. So what are the available biomarkers in acute kidney injury out there? You're going to hear a lot about this in the afternoon symposium. I'm not going to spend a lot of time, but this is a meta-analysis that was published by Chirag Parikh out of Yale, or now at Hopkins, looking at the available markers. A lot of these you'll recognize for established acute kidney injury: cystatin C, interleukin 18, KIM1, early detection, including INGAL, glutathione transferase or interleukin 18, and mortality risk prediction in AKI such as beta-NAG, in addition to KIM1 or interleukin 18. So this is really to kind of point out and lead us into the discussion of what's out there in regards to evidence for biomarkers in acute decompensated heart failure, right? That's what we want to know here. What, especially in regards to heart-kidney interactions. And surprisingly, there's not a lot of information out there. There's not a lot of trial evidence out there in acute decompensated heart failure. This is one trial looking at INGAL compared to serum creatinine. It wasn't necessarily superior in the akinesis study, but over time, KIM1 has largely fared better in this unique population. In several trials, this one just published in JACC Heart Failure a couple of years ago, KIM1 has consistently been elevated in heart failure patients and helped to improve risk prediction of mortality in these patients. So that's a fairly useful biomarker in this population. Now, whether it's clinically available at your institutions, that's another question altogether. But where I would like to end up over the next couple of minutes is talk about a new marker out there for acute kidney injury and heart failure, pink. And I don't mean the color pink, but proencaphalin A, which is secreted by cardiomyocytes and possibly the kidney. There's still some emerging data in that area, but it has a larger molecular weight. It is not filtered by the kidney, and it is non-protein bound. So in theory, it should be elevated in the heart failure patients and be a very sensitive predictor for heart injury and acute renal or acute kidney injury. And it has, over time, shown to be reliable for septic patients and in acute decompensated heart failure. And this is one trial of roughly about half a dozen that are sitting out there, just very consistently showing that it is elevated here on the right in acute kidney injury in the acute decompensated heart failure population. It has been strongly correlated to increases in serum creatinine, obviously, lower systolic blood pressure, and hyponatremia, and an indice of heart failure severity in these patients. But it's important to know that when we're developing these biomarkers, and I'm hoping to kind of set up our next couple of talks here, that when we establish these biomarkers, it's important to relate them to a clinically effective endpoint. So what does that mean? This was the basis of a whole a meeting and consensus statement by the Institute of Medicine in the United States a number of years ago. Because remember, biomarkers are measures of biologic processes. Makes sense, that's why they're developed, obviously. But they need to have properties as a valid surrogate related to a clinical endpoint. You know, a case in point might be cholesterol or LDL. You know, we have gone through years where using statins may lower LDL and improve cardiovascular outcomes in the general population, but maybe our dialysis patients, many of you may be familiar with, the statins didn't necessarily improve cardiovascular mortality. So is that a valid surrogate endpoint for that population? Not necessarily, right? So what is it that retains the property of a valid surrogate? What the Institute of Medicine puts out there is that the net effect of the intervention on that endpoint or that surrogate marker should reliably predict the intervention on the clinically meaningful endpoint. I think the LDL point and statin use in dialysis patients is a very constructive point in how we build these biomarkers. So it's not so much that the intervention can improve the biomarker that establishes the biomarker in a population. It has to be related to a clinically meaningful endpoint. So hopefully we have set the stage for where we're going to go over the next couple of talks, and then later in this afternoon talked about a few newer markers out there, ST2, galectin-3 in pink, but also understand the concept that we have to develop these markers with reliable, clinically meaningful endpoints, and that we need to apply very strict criteria for acute kidney injury in these trials. We've not been so good in setting these up through the years in how we evaluate these markers. And also to point out that in disease process, it may not just be one marker that we see come out in management down the road. It may be one or two, combining galectin-3 with BNP and how we manage our patients down the road, and to help us risk stratify these patients early in the disease course or late in the disease course. So just remember, we may be moving into an era where combining biomarkers may be most clinically meaningful. All right, and thank you so much.